Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club discussion is on the clinical transplantation article, Simultaneous Pancreas-Kidney Transplantation in Caucasian versus African American Patients. Does recipient race influence outcomes? And it is hosted by the AST's Kidney Pancreas Community of Practice. In a moment, I will turn the session over to our moderator, Dr. Ty Dunn from Penn Medicine in Philadelphia, Pennsylvania. Before we begin, however, we do have a few housekeeping notes to help us engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded and the archive will be available on the MyAST website 2 to 3 business days after the live session. Please note, all of your lines have been muted so that only the presenters can be heard clearly for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the website following the Journal Club. Finally, when you log off at the conclusion of today's Journal Club, you will see a link for a short evaluation survey. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Dunn, to begin our presentation. Dr. Dunn.
Thank you, Brian. First, I'd like to welcome all the attendees to our webinar this afternoon. It is such a privilege to introduce our speaker, Dr. Bob Stratta, who is professor and the Jesse H. Meredith Chair in Transplant Surgery and the director of the Transplantation Unit at Wake Forest Baptist Health, which is currently one of the largest kidney and pancreas transplant centers in the U.S. He has been active in medical school, surgical resident, and transplant fellow education since 1988 and has been a member of over 35 medical societies, numerous local, regional, and national committees, including the UNOS committees since 1988. Dr. Stratta has co-authored 6 books, 42 book chapters, and 480 peer-reviewed articles dealing predominantly with kidney and pancreas transplantation. He's lectured worldwide and has performed more than 2,500 transplants so far in his distinguished career. He's also the 2021 recipient of the IPEDA Richard C. Lillehei Memorial Award, which is given to an outstanding clinician and or scientist for the substantial contributions toward advancing the field of pancreas transplantation. He is one of the most experienced sages in the field of pancreas transplantation today. We are lucky he has set aside time with us so that he can share his recent work on SPK transplant outcomes in Caucasian versus African American recipients. Dr. Stratta, take it away.
Thank you, Ty. I echo Ty's sentiments, and we really appreciate you joining us today. And I want to thank the organizers for the opportunity to present this information. Next slide. So this is the article in question that we will discuss today with my co-authors. None of us have any financial disclosures or conflicts of interest to disclose. However, I would like to disclose that the terms Black and African American, white and Caucasian, and race and ethnicity will be used interchangeably in this presentation, because I still find it difficult to determine which one is politically correct. And then I'd also like to acknowledge Angelica Grusner for sharing the latest IPTR data. Next slide. So along with this study that we did in terms of race in kidney pancreas transplantation at Wake Forest, we also recently did 2 studies looking at recipient age and the issue of pre-transplant C-peptide levels, the so-called type 2 diabetes phenotype. And the reason I bring up these 3 papers is because there's a lot of clinical overlap when you're looking at these patient populations in terms of minorities, recipient age, and the presence of the type 2 diabetes phenotype. Next slide. If we look at International Pancreas Transplant Registry data, and this is looking at 5-year periods from 1997 to currently through 2021, we'll focus on the red bars, which are simultaneous pancreas-kidney transplants. This is the number of patients with a type 2 diabetes phenotype that were transplanted in each of these 5-year periods. So in the most recent 5-year period from 2017 to 2021, there were over 900 people who were identified on the TIDI forms as having a type 2 diabetes phenotype who received pancreas kidney transplants in the US. Next slide. And if we look at the proportion or percentage of people in each of these 5-year periods of time that are receiving kidney pancreas transplants, back in the late 1990s, only about 5% of pancreas kidney transplants were performed in people identified as having type 2 diabetes. And in the most current 5-year period, 2017 through 2021, about 23% of patients have been identified as having a type 2 diabetes phenotype. Next slide. Now, the reason this is relevant is because there's a relationship between so-called diabetes type and race. And again, this looks at International Pancreas Transplant Registry data, looking at race according to whether patients were identified as having type 1 or type 2 diabetes. And on the left-hand portion of the slide, if we focus on the gold bar, for type 1, the majority, about 55%, are Caucasian or white, and the green bar, about 25%, are identified as Black or African American. If we shift over to the right side, patients identified as having type 2 diabetes, actually the most common race is Black or African American. Over 40% of people identified as having type 2 diabetes are Black. And then the Caucasian in gold and Hispanic, kind of in a reddish color, are almost equally included, about 20 to 25% of the type 2 diabetics. So that clearly minority access becomes an issue and improves when pancreas kidney transplants are being performed in people that are not classic type 1 diabetics. Next slide. And then age also factors into this as well. These are box plot and whisker analyses, again, looking at 5-year periods of time. And the greenish box plots are type 1 diabetes, the yellow are type 2. And you can see in the early 1990s, the majority of patients were type 1 diabetics, and the average age at the time of transplant was about 38. And if we look at the most recent 5-year period, 2016 to 2020, as I mentioned, a good proportion of these, 25% or so, are type 2 diabetics, and the average age of people undergoing simultaneous pancreas kidney now is in the early to mid 40s. And each of these 5-year eras, the people identified as having type 2 diabetes were older than people identified as having type 1 diabetes. So when you're talking about race, when you're talking about type of diabetes, when you're talking about age, they're all interrelated. Next slide. And this just shows another type of graphic showing the proportion of patients in each pancreas transplant category identified as type 2 diabetes. And as I mentioned in the most recent iteration of the data, about 23% of people undergoing simultaneous pancreas kidney transplant, that's the red line, are identified as having type 2 diabetes. Next slide. And this parallels the number of African American recipients in each of the 3 pancreas transplant categories undergoing pancreas transplantation. And currently, just under 30% of people undergoing simultaneous pancreas kidney transplant are African American. Next slide. So at present, African American patients represent about 30% of SPK transplants. Many African American patients have what we refer to as a type 2 diabetes phenotype, characterized by a later age of onset of diabetes and an older age of transplant, no history of diabetic ketoacidosis, absence of autoantibodies. And many centers define type 2 diabetes in terms of the presence of measurable or a certain level of C-peptide prior to transplant. These patients tend to have a higher BMI in the high 20s or low 30s versus the mid to low 20s. And many of these patients were not immediately insulin requiring at the time of their initial diagnosis for diabetes. Now we know historically, predominantly in kidney transplantation, but also in pancreas kidney, that African American recipient ethnicity may be associated with diminished graft survival and increased acute rejection. And the development of post-transplant diabetes compared to Caucasians. Next slide. So I'd like to review some of this data and look at the history of race on outcomes after kidney and kidney pancreas transplant. This was one of the first papers. It was published in 1997. It comes from Vic Dujan, who looked at their experience when he was at MUSC and then at UT Galveston. And they had 118 kidney patients, 33 Black and 99 SPK, 13 Black. And they noted no significant differences in graft survival or rejection, although there was actually slightly higher kidney pancreas survival in the Black recipients, but this was not significant, and it was only an N of 13. And then Vic and colleagues did a similar analysis, but only looked at the COF database, and but basically did the same study, and they identified 98 Black SPK recipients in this study, and they noted that there were no differences in patient or graft survival in the SPK patients, but the Black patients did have some differences compared to their Caucasian counterparts. Next slide. George Burke reported on 98 kidney pancreas transplants at Miami, only 2 of which were African American. Both were successful, but both had rejection. And then there was this interesting article from the Ross Isaacs and the University of Virginia group looking at striking racial disparities in access to SPK transplant, which may be related to employment status and access to insurance. Next slide. Hold on just a second. There we go. When I was at Memphis, we did a small study. We compared 10 African American versus 10 Caucasian SPK recipients, and the Caucasians were matched with the African Americans for age, gender, weight, timing and technique of transplant, and immunosuppression. We noted 100% kidney and pancreas graft survival in the Caucasians, 80% in the African Americans. The 2 patients had dual immunologic graft losses. So African American patients had a longer length of stay, more readmissions, and a higher rejection rate compared to the Caucasians. Next slide. However, the father, or even godfather, if you will, of kidney pancreas transplantation, not only in type 2 diabetes, but in African Americans, was Jimmy Light at the Washington Hospital Center. And in transplantation in 2001, he reported on their 10-year experience with 136 SPK transplants, including 49 in African Americans. 60% of them were identified as being type 1 and 40% type 2 diabetes based on a pre-transplant C-peptide level less than or greater than equal to 0.8 nanograms per ml. Patients with so-called type 2 diabetes were older, had older age of onset of diabetes, had a higher BMI, and were twice as likely to be African American. Patient and graft survival rates were slightly but not significantly higher in African American SPK recipients. Next slide. So they concluded that neither type of diabetes nor recipient's race plays any role in the outcome of SPK transplantation. And the reason I highlight this is this is a very important takeaway or take-home concept. Next slide. Jimmy Light then reported on their 20-year experience with 173 SPK transplants, 51% or 88 of which were African American, and 58 were identified as having type 2 diabetes. Again, type 2 diabetes more often African American, older clinical diagnosis of diabetes, and at the time of transplant, higher BMI, shorter need for insulin, and had greater post-transplant weight gain. And the reason I highlight this is as we look at more of the recent experience with type 2 diabetes, post-transplant weight gain really becomes an important outcome, and it can lead to insulin resistance and pancreas graft failure in some of these folks. In their 20-year experience, patient survival was higher in type 1, but censored kidney and pancreas graft survival was higher in type 2 diabetic recipients, and they noted no differences in rejection. Next slide. So they said that SBK candidacy should be based on clinical criteria such as age, comorbidities, BMI, and not based on race. Next slide. The Jeff Rogers, when he was at MUSC, reported on their experience with 63 Caucasian and 33 African American SBK recipients. They noted no differences in patient or graft survival, although pancreas graft survival was somewhat worse in the African American recipients, and the cumulative incidence of acute rejection was higher in African American patients, suggesting that tailored immunosuppressive strategies may need to be considered in this situation. Next slide. And then Dr. Rogers, along with us, performed an ad hoc analysis of 297 SBK recipients, 37 of whom were African American. And this was a study of teclistamab induction, multi-center randomized prospective, looking at 2 dosing regimens of teclistamab versus no antibody induction. And we found no differences in patient or kidney pancreas graft survival or rates of rejection according to race at 3 years follow-up. But the African American patients did have higher serum creatinine and hemoglobin A1C levels and lower GFR. Next slide. The group at Tulane reported twice in the literature. The top citation is in 2007, and then in 2009, they reported their later experience with pancreas transplantation in African American patients using basiliximab induction. And they identified 45 African Americans, 36 SPK, 6 PAK, 3 PTA, and compared these patients to 73 white, 55 SPK, 13 PAK, and 5 PTA recipients at Tulane. And at 7 years follow-up, there were no differences in patient or pancreas graft survival rates, but a slightly higher incidence of acute rejection in the African American patients, but no differences in infection or graft function. Next slide. Donna Hathaway and her colleagues at Memphis did an exploratory descriptive study of social support networks in 258 transplant recipients, including 66 XPK and pancreas alone. And they found that sex, race, and social class had no main relationships with structure and type of support. However, African Americans had significantly higher levels of frequency and duration of support compared to whites, which was a bit of a surprising finding. Next slide. The group at Hopkins performed a retrospective SRTR database study of the impact of Medicare coverage for SBK and PK, which occurred in July of 1999 on waiting list access. And the presence of Medicare coverage for these types of pancreas transplants increased overall SBK registration rate by 27%, especially for those who had Medicare as their primary insurance. However, racial disparities were unaffected by the policy change, as African Americans and Hispanics continue to have almost 30% lower SBK waitlist registration rates compared to their Caucasian counterparts. Next slide. Luan and the group at Michigan performed a retrospective SRTR database analysis of 6,585 SBK transplants performed in the US between 2000 and the end of 2007. There were 931 African American SBK recipients. They were noted to have longer dialysis vintage, fewer private insurance, shorter diabetes duration, more were identified as type 2. No differences in patient survival between African American and Caucasian patients, but African American patients had a 38% and 47% higher risk for late death-censored kidney and pancreas graft failure, respectively. Next slide. Then the group at Toledo also performed a retrospective SRTR database analysis, but included 20,196 SBK transplants from 1989 to 2014, and this included 2,708 African American patients. And this group looked at 4 different races: Hispanics, Asians, Caucasians, and African Americans. And interestingly, at 10 years, Hispanics and Asians had the best patient and graft survival outcomes compared to whites. African American patients had superior 1- and 3-year patient and graft survival outcomes compared to whites. However, starting at 5 years follow-up, African American patients had inferior patient and kidney graft survival rates compared to all other races. So at 10 years, the Hispanics and Asians had the best outcomes, whites had intermediate outcomes, and the African Americans had the lowest outcomes. Next slide. Carlton Young and his group at UAB performed a single center retrospective study of 188 SPK transplants from 1999 to 2014. And this included 68 African American patients. They compared this group to 120 white patients undergoing transplant at their center, as well as SRTR data of 5,523 concurrent SPK transplants performed at other centers. And they reported quote unquote equivalent outcomes in African American and white cohorts at UAB, both of which were superior to concurrent national data. However, there was a 17% increased risk of death, 27% increased risk of kidney, and 15% increased risk of pancreas graft loss in the African American group compared to Caucasians. Next slide. The group at MUSC then performed a single center retrospective longitudinal cohort study of 287 pancreas transplants, of which 217 were SPK. And this included 162 non-African American and 125 African American recipients. The African American patients had higher rates of pancreatic leaks, postoperative bleeding, and kidney rejection. Patient and pancreas graft survival was comparable, but the kidney graft survival was inferior in the African American patients. Next slide. And then the latest retrospective SRTR database analysis included 28,797 primary pancreas transplants from 1989 to 2018. This included 3,828 African American recipients, which was 13.3% of the entire cohort compared to other races. And before 2009, the hazard ratio for pancreas graft failure at 3 years was 1.16, or a 16% increased risk for African American recipients. And prior to 2009, they had higher graft loss due to rejection. However, after 2009, the hazard ratio for African Americans dropped to 1.01. However, from 1998 to 2018, a univariate analysis in SPK recipients showed that African American patients, although they didn't have a difference in patient and pancreas graft survival, they did have significantly decreased kidney graft survival. Next slide. And then Lisa McElroy and Jonathan Friedel, commenting on this SRTR analysis, stated that the author's findings reinforce prior reports of national pancreas transplant outcomes that show continued improvement in short and long-term clinical outcomes. The study predictably limited by lack of nuanced information, such as immunosuppression, resource utilization, and social determinants of health. And then they also commented in this editorial on our paper, which I'm about to present. And they stated that Black patients are overrepresented, of 40% at Wake Forest, and the detailed explanation of the program selection criteria and approach to care demonstrates the power of center-level practices to influence racial equity and access to care. And I think this is really a nice summation of when you're looking at registry data, which does not always have granular information on rejection, resource utilization, et cetera, compared to single center studies that may have more granular information, but have fewer patients and may not have the power to detect a significant difference. Next slide. However, the good news is that the recent SRTR report suggests that access may be improving for minorities. As you see the bottom 3 lines, the green line is Black, and the light blue line is Hispanic. And so the proportion of patients being placed on the waiting list for simultaneous pancreas-kidney or other types of pancreas transplant is increasing in these groups where it's actually decreasing amongst whites. Next slide. And next slide, I just want to talk about the latest IPTR data. As many of you know, in the last 8 years or so, the number of pancreas transplants performed in the United States has plateaued. It's currently less than 1,000. Next. Now, if we look at SPK patient survival in type 1 diabetics according to race, the blue line is Hispanic, green line is white, black line is black. I'm sorry, red line is black. And there's no significant difference at 3 years in patient survival according to race in type 1 diabetics. Next slide. If you do the same analysis for type 2 diabetics, again, no difference in SPK patient survival at 3 years. Next slide. Now, if we look at pancreas graft survival according to race, type 1 diabetics, it actually trends to be a little bit higher in the Hispanics, which corroborates some of the previous SRTR data, and blacks and whites, pancreas graft survival at 3 years is roughly equivalent. Next slide. If we look at type 2 diabetics, there's really no signal to speak of. The Hispanics numerically have a higher pancreas graft survival at 3 years. Blacks and whites are nearly identical. Next slide. However, if we look at kidney graft survival in SPK recipients in patients with type 1 diabetes, the kidney survival at 3 years is statistically inferior in blacks compared to Hispanics and whites. Next slide. But when we look at type 2 diabetics, interestingly, we don't see the same signals that are all roughly the same. Next slide. So I'd like to talk a little bit about our pancreas transplant program, which began in November of 2001. And this shows the number of transplants that we've performed in the new millennium. And our program, similar to others, suffered that decade of decline from about 2005 to 2015. But the numbers have picked up in recent years. And we're currently doing in excess of 20 pancreas transplants per year. Next slide. And this arrow just shows the study period for our study on race from November of 2019 through November of 2001 to February of 2019. Next slide. So during this time, we performed 266 pancreas transplants in 256 patients, 220 were SPK, and this is what we're going to focus on. Next slide. And one of the reasons why our numbers are increasing in recent years is because we are performing more pancreas transplants, SPK transplants in patients that are identified as type 2 diabetics, that's the green bars, or in minorities, that's the yellow bars. Next slide. And if we look at ethnicity in these 220 SPK transplant patients, 158, 72% were Caucasian, 57 or 26% were African American, and the remaining 5 were excluded from the study, and that included Native American, Hispanic, and Asian. So our study group is 215 patients, Caucasian versus African American. Next slide. Among these 215 SPK transplant recipients, 82% had C-peptides prior to transplant less than 2, and 38 or 17.7% had a C-peptide greater than or equal to 2, which is what we use as our definition for a type 2 diabetes phenotype. Next slide. Surgical technique was primarily portal enteric and 89%. There were 10.7% that were performed with systemic enteric drainage. Next slide. And this just shows the 2 techniques, the portal enteric on the left and the systemic enteric on the right. Next slide. And since I'm a surgeon, I have to show a requisite intraoperative diagram, otherwise I would be canceled from the surgical guild. So this shows a pancreas transplant following reperfusion and performance of the enteric anastomosis. Next slide. Depleting antibody induction occurred in all patients. The majority received a single dose of alemtuzumab, the remainder multiple dose rabbit ATG. Next slide. So from 2001 to 2004, rabbit ATG was our primary induction agent. We used 3 to 5 doses, 1.5 milligrams per kilogram per dose. And since 2009, alemtuzumab has been our primary induction agent. And what happened from 2005 to 2008 is we performed a prospective trial of alemtuzumab versus rabbit ATG induction in our kidney and kidney pancreas population. And we found that there were certain advantages to the alemtuzumab, and that's why we switched exclusively to alemtuzumab starting in 2009. So the majority of the patients in the study did receive single dose alemtuzumab induction. There was no difference in the method of induction in the study groups. Our maintenance therapy is triple therapy with tacrolimus, full dose mycophenolate, although early in this experience it was CellCept before Myfortic became available circa 2004, 2005. And then rapid prednisone taper, dose reduction to 5 milligrams per day by 1 month following simultaneous pancreas-kidney. But we do not perform steroid elimination or steroid withdrawal. Next slide. A lot of data here. I just want to focus on the shaded areas. So the left-hand column is our 57 African-American patients, and the right is our 158 Caucasian patients. So donor age was about 4 years younger in the African-American cohort. And then if we look at donor race, gender, weight, BMI, kidney and pancreas cold ischemia, no differences. About 2/3 of the African Americans were a 5 to 6 HLA mismatch versus half in the Caucasian group. So the HLA mismatch mean was statistically higher in the African Americans versus Caucasians. And more of the African Americans had a CPRA of 20% or higher versus the African Americans. And fewer of the African Americans were CMV recipient negative, whereas fully half or more of the Caucasians were CMV seronegative. So numerically, there was a little higher incidence of primary CMV exposure in the Caucasians versus African Americans, but this was not significant. Retransplants, systemic enteric technique, organ import were not statistically different. Next slide. Look at recipient characteristics. Again, the African Americans on average are about 4 years younger than the Caucasians. No difference in recipient gender, weight, BMI. However, if we look at dialysis history, African Americans, most of them were on hemodialysis, fewer of them were on peritoneal dialysis, and the number of preemptive transplants was comparable in the two groups. Duration of dialysis was slightly longer in the African Americans, but when we broke it down to look at dialysis for 20 months or longer, it was significantly longer in the African Americans. More than half had been on dialysis for a minimum of 20 months. Duration of diabetes was shorter in African Americans. Insulin use less than 20 years was more frequent, double compared to Caucasians. Age of onset of diabetes was older in African Americans. And when we looked at age of onset at age 24 or older, it was twice as likely in the African American group. And then pre-transplant C-peptide of 2.0 or higher was about 3 times more common in the African American group versus the Caucasian group. Time on the waiting list was very similar. Next slide. And this just highlights the variables that we use to suggest a type 2 diabetes phenotype. Age of diabetes onset greater than equal to age 24, C-peptide greater than equal to 2, diabetes duration being shorter, and being on insulin for less than 20 years being more common in the African American versus non-African American group. Next slide. So we had a mean follow-up in excess of 8 years in each group, and these are the overall survival data. The African Americans, interestingly, had slightly higher patient survival at a p-value of less than 0.10. Kidney survival was no different. Pancreas survival was no different, although numerically it was slightly higher in the African Americans. No incidence in early relaparotomy, early thrombosis, and no differences in acute rejection. Next slide. We look at actuarial patient survival. Next slide. We start to see a little bit of a signal after 6 or 7 years, suggesting that Caucasians are experiencing more late deaths, but this did not reach significance. Next slide. If we look at kidney graft survival, next slide. It looked like there was starting to be a signal at about 4 years where the African Americans were starting to experience lower kidney graft survival, but then this equalizes later on. And as I'll discuss, it's probably related to more deaths with a functioning graft in the Caucasian group. But again, it was not statistically significant. Next slide. No difference in actuarial pancreas graft survival in the two groups out to 10 years. Next slide. Now, if we look at death-censored survival outcomes, and this is where we see that there were more Caucasians experiencing death with a functioning graft. No difference in kidney survival. Pancreas survival was identical. And I mean, you can't make up this data. The numbers are the numbers. However, death with a functioning graft was almost twice as common in Caucasians, whereas death-censored dual graft loss was 3 times more common in African Americans. And this is censored not only for death with a functioning graft, but also censored for early kidney or pancreas graft thrombosis. So we were looking at people predominantly who were losing both grafts at medium-term follow-up in the absence of death and in the absence of thrombosis, which we believe is mainly immunologic in origin. Next slide. So if we look at the death-censored analysis, next slide, we see that signal again at 4 years, where there seems to be a little bit of a drop-off in the African Americans. And whether this could be related to the fact that the Medicare coverage runs out at 3 years is an interesting speculation. And as I showed in some of the previous literature, particularly in the registry data, it does suggest that there is lower kidney graft survival in African American SBK recipients. However, this did not achieve statistical significance in our study, and perhaps because of small numbers. Next slide. Pancreas graft survival, no different. Next slide. So in summary, in our African American group, both donors and recipients were 4 years younger than in the Caucasian group. And one might say that this, could make a difference in terms of the outcomes that we reported. However, late mortality was 4 times more common and death with a functioning graft twice as likely in the Caucasian group compared to the African American group. Consequently, we began to see a divergence in patient survival at 8 years and kidney graft survival rates by 4 years, but we never identified any differences in pancreas graft survival rates. And the African American group was characterized as having more patients with detectable HLA antibodies, more HLA mismatching, more patients with a type 2 diabetes phenotype, fewer PD patients, longer dialysis duration. And there was in dual, which we speculate could be immunologic graft loss because it was sensitive for death and early thrombosis. So dual graft loss was 3 times more likely in African American versus the Caucasian group. Next slide. So although actual survival rates in the instances of early thrombosis, early relaparotomy, and acute rejection are similar, African American patients are at greater risk for death-censored kidney graft loss and dual graft loss in the absence of mortality or early thrombosis, whereas non-Hispanic Caucasian patients are at greater risk for late mortality and death with a functioning graft. This may imply that African American patients have either a greater risk for dual graft loss, better survival in the presence of graft loss, or both. And the divergent timelines and disparate causes of graft loss may have important implications on how to improve long-term outcomes and manage these patients long-term. Next slide. And I'd be happy to entertain any questions and discussion. Thank you very much for your attention.
Thanks, Dr. Stratta, for your really comprehensive and excellent presentation. I'd like to invite the audience again to continue to submit questions in the chat. We have some coming in. And while we're waiting for those, I have a couple of questions for you. You had mentioned in your paper that you had plus minus steroids as part of your methodology for maintenance immunosuppression. Was there a difference between groups in that, or did you treat the African American patients differently in terms of access to steroid-free?
We did not, and some of that occurred when we were doing our randomized or prospective trial from 2005 to 2008, comparing rabbit ATG and alemtuzumab, but race was not an issue. And over time, there was the bandwagon of doing steroid elimination in the early 2000s, and now I think this. The pendulum has swung maybe back towards using low-dose prednisone long-term, and so the majority of these patients were managed with steroids long-term.
Thanks for that. This is just kind of a contextual question, kind of partners with one from Dr. Rao at UVA, wanting to know if you did protocol biopsies and if pancreas biopsies, were they done when rejection was suspected, or did you do the kidney? And did you see a difference in disease recurrence for type 1s between the two races?
Good questions. So we only do protocol pancreas biopsies when we do a solitary pancreas transplant, either a pancreas alone or a pancreas after kidney. And because the organs are intra-abdominal with a simultaneous pancreas-kidney, although we do surveillance 1-month biopsies in our kidney alone transplant population, we were a little more reluctant to do the surveillance kidney biopsies with an intra-abdominal kidney because of potentially a higher risk for bleeding. Our diagnosis of rejection, if the pancreatic enzymes go up and the creatinine is normal, we would biopsy the kidney first. And in our experience, that usually is a pretty good indicator of what's going on with both organs. I know the data shows there's about 60% concordance with kidney and pancreas rejection, and then 20% discordance with kidney without pancreas or pancreas without kidney rejection. We do pancreas biopsies. As you probably know, we can't always get a safe window to do the pancreas biopsies, but we rely mostly on the kidney as a marker for rejection, although we will biopsy the pancreas if the kidney biopsy is negative. And of course, in the last few years, we've been using the biomarkers, the cell-free DNA, more and more in the kidney pancreas population. And our experience suggests that it's as useful as in the kidney alone population. In particular, if the cell-free DNA levels are low, then the chance of rejection is very low.
Great. And just to follow up that, we have an anonymous attendee that just wanted to clarify in your center's personal experience, you had mentioned the 60% concordance rate, but did you find your data to be any different when you did biopsy both grafts? Lots of questions about rejection here.
Yeah, we rarely biopsy both grafts. Okay. And I haven't looked at that data systematically, but I tend to agree with that data from the literature, and that's been, I guess, more or less of our experience, although, as I said, I haven't scientifically looked at it because we usually don't. We send the patients for a kidney and pancreas biopsy, and they're done under ultrasound guidance by the radiologist, but the radiologists are always very reluctant to do the pancreas biopsy, and they'll do just a kidney biopsy.
Yeah. Okay. Still looking for additional questions. I have a couple, and I think you actually touched on this a bit in your presentation, but I wanted to draw out a little bit more of your perspective on this actual situation. So when you show the life tables for death-censored kidney graft survival, and you showed that they diverged around the post 3-year mark for kidney between the two races, and obviously that's suggesting more of an immunologic cause of graft loss, as you pointed out, for the African Americans. When you did your early and late multivariate analyses, did you include insurance type, public versus private, as one of the recipient variables? I didn't see that spelled out as included or not. And I'm just curious to know if you had to do it again, would you be interested in doing that?
It's a good question. The vast majority of these patients are Medicare primary. We don't have a lot of private insurers for the kidney pancreas transplant. But we did, about 15 to 20% were preemptive. It's something that we can and should look at. I haven't done that to date.
All right. It's interesting that you didn't see the same divergence in the pancreas set. And I'm curious to think, would you agree that it may be because you didn't have as many biopsies there, or that it's more difficult to report graft loss?
Well, I mean, if a patient's not on insulin, that's a graft success. If a patient's on dialysis, that's a graft failure. So it's an interesting conundrum, if you will. But it's something that was unexpected, but it is something that I've tracked over time. And there was a clear difference, although I couldn't necessarily show it statistically, that much more death with a functioning graft, particularly late in the Caucasian group. And there is previous data suggesting that Blacks or African Americans have better patient survival after kidney transplant than whites. And then, of course, there's previous data suggesting that they have inferior kidney graft survival after SBK transplant compared to whites. But the patterns and the timing of graft loss were quite different, where we were getting, in the African Americans, they would lose their kidney and their pancreas within a few months of each other. And it wasn't because we were stopping their medications. But I think clearly there's a compliance issue there. There may be an insurance issue. And I think one of the takeaways or take-home points is we need, as transplant centers, to be more actively involved in following these patients long-term. Because historically, we would send the patients back to their nephrologists or primary care doctors after 1 year, and we would see them once a year thereafter. I think if you're going to try to improve medium or long-term outcomes, we probably need to be seeing these patients every 3 months long-term at the transplant center. And particularly in that 3, 4, or 5 hour window where they tend to get 3, 4, 5 year window where they tend to get lost in the shuffle, if you will. And they'll just show up one day and they'll say, yeah, I ran out of medications and I didn't renew my prescription or something like that. So, is it the transplant center's responsibility to manage that long-term? I think there's a signal in the data to suggest that we could get better long-term outcomes in certain patient populations if we did that.
Yeah, that's a great observation. I tend to agree with you wholeheartedly. We have some new comments coming in. Dr. Friedel congratulated you on your impressive outcomes. He assumes that your selection process with regard to race, age, and diabetes has evolved over this longer term experience that you all have at your center. And have you ever considered looking back at the kidney alone transplants from about a decade ago to identify recipients that would have now met criteria and offered a PAK?
Many of them gain weight and they don't meet BMI criteria, although we've been relatively aggressive with C-peptide levels. We've transplanted people with C-peptide levels as high as 12 to 15, and we've transplanted people with SPK up to age 60. We've always been very conservative with BMI. We rarely go above 30. And most of the patients who are excluded for kidney pancreas is because of BMI, or if they get a kidney alone, they gain weight being on the prednisone and feeling better, having a better appetite. So, I mean, we monitor those patients, and I think we could do a better job if we had, like a pancreas whisperer, a coordinator that was strictly dedicated to looking at our diabetic kidney alone patients to determine who might benefit from a pancreas after kidney. It's a good observation, and Dr. Friedel and others have clearly shown that is one very successful way of growing your pancreas transplant program.
We have a question from Dr. Haririan wanting to understand how you might use total daily insulin dose in terms of your selection criteria.
So, all of this is arbitrary, right? Jimmy Light started by using 0.8, and that was the line in the sand for the C-peptide. And we decided to use 2 because there was data at that time suggesting that if someone had a C-peptide of 2 or higher, that regardless of whether they were on dialysis or not, that clearly met criteria for insulin resistance and type 2 diabetes. So, you can quarrel or quibble with what line in the sand you draw. But I think daily insulin requirements are important. We don't have great data on it, just like BMI, we're a little bit reluctant to go above 30. If someone has an insulin requirement in excess of 1 unit per kilogram per day, we consider that a bit of a deal breaker. But most of those patients also don't meet BMI criteria. So we've done a couple of people that maybe were on up to 100 units of insulin per day, but we used the 1 unit per kilo per day, right or wrong, as our line in the sand to try to prevent graft loss due to insulin resistance.
And to follow up on that, how do you think about that daily insulin requirement in the context of renal failure for an SBK candidate versus someone that's already on TAC with normal renal function? Are you more liberal in the PAK patient for total daily requirements?
Good question. I guess I don't really have a lot of experience with that. As I said, I find that the BMI usually is a deal breaker more than the insulin requirements. Now, with other ways of treating diabetes now, non-insulin alternatives, it turns everything topsy-turvy now, because people can be treated with 2 or 3 or 4 oral medications or non-insulin derivatives, but you're supposed to be on insulin in order to qualify for a pancreas transplant. So how do we work that into the equation?
All right, we do have.
And if someone is on oral anti-diabetic agents, but they're not on insulin, is that a pancreas graft success or failure? You get into some really interesting questions because in the past we identified failure as need for insulin.
Yeah, interesting questions for sure. We do have a congratulations from Dr. Parsons coming in for your great presentation and a thank you. He wanted you to comment again on the duration of diabetes and the risk for long-term outcomes as you see it broken down between the races.
Well, first of all, I've never seen data to suggest that duration of diabetes affects outcomes. I think there was one paper I saw, but I've looked at that over 30 years of doing pancreas transplants, and duration really never affected outcomes. Much like, I guess, race in some respects doesn't affect outcomes either if you're selecting your patients appropriately. Now, with the patients that have a shorter duration of diabetes, and the unspoken issue here is if you see someone who's on 10 units of Lantus insulin, they've only been on insulin for 5 years, but they have kidney failure and they don't have a living donor, well, you can get them a kidney pancreas transplant a whole lot faster than you can get them a kidney, and you're going to get a higher quality kidney with the kidney pancreas than you are the kidney. So for that individual patient, you're helping them tremendously. You're getting them transplanted faster with a higher quality kidney. The issue has always been, well, then does that take away from the non-diabetics on the waiting list? And the important takeaway there is the number of total pancreas transplants is decreasing. Circa 2000, about 11 to 12% of kidneys in the United States went for kidney pancreas transplants. In the last 2 years, it's only about 5%. You have more of the kidneys going for liver kidneys and heart kidneys in some respects than you are for kidney pancreas. So the concern has always been the preference or the favoritism, if you will, of doing a kidney pancreas in a type 2 diabetic who doesn't have 20 years of insulin duration. But the reality, the data suggests that it's not really taking away from the non-diabetics on the kidney alone waiting list because the numbers just don't add up. We're not doing hundreds and hundreds of type 2 diabetics and taking all these kidneys away from others.
Hear, hear. I don't have any other questions in the chat. We are nearing the end of our hour together. I'd like to again thank Dr. Stratta for his presentation and for everyone that joined our webinar today. Brian, back to you.
Well, thank you so much. AST would like to thank Dr. Stratta and Dunn and all of our attendees for today's session. Please remember to complete the evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about the AST Kidney Pancreas Community of Practice, please visit myast.org/COPS or connect directly to the KPCOP Hub. Thank you all again for today's great session.